to take us, I think, a bit further than perhaps we've gone before into this rather complicated but truly important subject area where the best of science needs also to be bolstered by the best of compassion, the best of a humanistic approach to care, to healthcare. So I want to welcome everyone to this, especially folks online, to our annual Crawford Lecture. This is an opportunity for the School of Nursing and Health Professions to do a larger outreach to our alumni, and to our larger community, and present a topic of importance, a topic of interest, but also a topic that might inspire us to rededicate ourselves to whatever aspect of healthcare where we are engaged. So thank you very much to those who've joined us in person and to those joining us online. Welcome.
Thank you, Father Paul. It's always inspirational for us. So thank everyone for joining us tonight. We have pondered on this topic for a while. It's a very needed conversation, as Father Paul has just identified. We have opioid use disorder and hope for healing that just keeps rising to our awareness as health professionals in higher education and as members of the community. So we're all challenged with this. It touches all of our lives. I want to personally thank Alicia and Dr. Evan Kletter for their participation tonight. I can't wait till I can say the doctors Kletter. We are very grateful to them to serve as our keynote speakers. They have amazing expertise and knowledge to guide us in this and help us reflect on how we can help in this epidemic. So I also need to thank just a couple of other people. We wanted to have an interdisciplinary conversation because the topic calls for it, and so that is what we compiled. The faculty panel includes Charlisa Bird from the School of Education, and from the School of Nursing and Public Health, we have representing nursing, clinical psychology, and public health. We have Drs. Trinette Radaza, Dr. Yvette Mahmoud-Ozer, Dr. Fidian Green, who will all address different perspectives needed to approach our communities. The thanks we have are many. First, I want to recognize the graduate nursing faculty and Assistant Dean Alexa Curtis, who, with her experience, has helped advise us on this lecture. I also want to thank Ms. Geraldine Crawford for her endowment for the lecture, for her insight and forethought to facilitate learning experiences for all of us. And I really want to thank Caroline Echeverria for organizing and shepherding us tonight. The staff support includes Cynthia Ordaz, my assistant Yoshi Yamaguchi, and Megan Claypool from management. And last, the Women and Leadership and Philanthropy group has served to support us. So we've fielded all the questions that have come in, and we will present them in the panel afterwards. And so as we prepare for this, I want to ask Alexa Curtis, there she is, to go ahead and step forward, and she'll introduce our speakers. Thank you.
Thank you, Dean Pierce. So it is my distinct honor and pleasure to do the official introduction here to our distinguished speakers today. You've all had the opportunity to review their biographies of this accomplished speakers that is provided on the event registration page. Cumulatively, they represent decades of experience treating substance use disorders, co-occurring mental health issues, and expanding access to care among underserved populations. They have been innovators in this space long before many of us became aware of the true extent of the needs surrounding opioid use disorder within our communities. Exemplifying a commitment to professional excellence and lifelong learning, Alicia is completing a Doctor of Nursing Practice degree at USF with a psychiatric mental health specialty focus. Her scholarship and nursing practice will continue to be applied in the service of others in our community. Alicia's husband, Evan Kletter, is a University of San Francisco trustee who embodies the social justice mission of USF, leading the vision of addressing inequities among the most vulnerable to create a more humane and just world. We are tremendously grateful to have the opportunity to spend this evening with the both of you. Please help me in welcoming Alicia and Evan Kletter.
Thank you. Thank you so much for that warm welcome. We are really excited to be here. Welcome to all of you in this room and everyone joining us on live stream. As Father Fitzgerald mentioned, Evan has healthcare and the desire to help people in his blood. His father was a clinical psychologist, his mother a nurse. Social justice mattered to them. When Evan was young, his family lived in Manhattan's Lower East Side. His father worked in methadone treatment in its infancy, and his mother worked in addiction in the Bowery. During those early years, Evan's parents invited a teenager to come live with them in their apartment, a teenager from the apartment building in the Lower East Side. His name was Kevin. Kevin really integrated himself into Evan's family. He was a friend, a babysitter. It wasn't until later in life that Evan realized Kevin had been kicked out of his own home because he was addicted to heroin, and Evan's family took him in and got him into methadone treatment. Evan's family eventually moved to San Francisco, where his parents started businesses, a business of clinics providing substance use disorder treatment and mental health care. Evan worked his way up in that business, eventually becoming an executive, but his very first job was reconciling Medi-Cal bills, and his second job was collecting urine samples from patients in treatment. From humble beginnings, Evan's desire to help was solidified, and I just wanted to share that extra story with all of you.
Thank you. And so, you know, healthcare is also in Alicia's blood, and she grew up on a dairy farm in New York, and there she is up there, pictured with maybe one of her first patients, an animal. Her first patients were animals, maybe willing or unwilling patients. Her mom was a nurse, and her grandfather, uncle, aunt, and older brother were all physicians. Alicia thought she would probably be a physician too. But while studying for her own medical school admission tests, she met a nurse practitioner. And she knew right away that the holistic, patient-led approach to care was a perfect fit for her. She became a nurse in 2003 and worked in an emergency room in Oakland. She quickly developed a reputation as the person who her colleagues sent all the difficult patients to, the drug addicts and the junkies. During her nurse practitioner program, she interned at a methadone clinic. This shifted her entire career path. She accepted a job there as soon as she graduated. She's a passionate advocate for patients, and she uses education as a tool to change minds and encourage people to think differently about opioid disorders. She uses education to challenge biases against effective treatment modalities and the patients who need them. If you need a nurse, this is the nurse you want. Now, if you're a spouse with a common cold, you won't get any compassion from Alicia.
I can confirm
if you have
that.
a drug problem, this is who you want in your corner. So with that extended introduction to our work, let's dive into the history of opioid addiction before discussing what we can do to make a difference. The history of opioid use is fascinating. Opioids have been with us for a long, long time. As we will see, opioid use patterns exist in a cycle in this country dating back 200 years. The cycle starts with scientific innovation to manage pain, followed by addiction and stigmatized communities and governmental regulations, backlash for patients and medical providers, and then the cycle repeats. To understand how we got to where we are now, let's go back to the early 1800s. The first cycle starts with the isolation of morphine in 1806. Then, thanks to the hypodermic needle, a highly powerful opioid medication could be delivered rapidly. In the Civil War, morphine was heavily used as pain reliever, and veterans became addicted. Morphine was a cure-all used to treat pain, anxiety, tuberculosis, and female disease, whatever that was meant to mean. Increasing use was fueled by self-medication, opioid-laced medications, and the spread of opium smoking. It's worth pointing out, since history repeats itself, that physicians helped create this late 19th century opioid epidemic. In the 1870s and 1880s, per capita opioid use in the US had tripled. The cycle continued. Scientific innovations produced heroin from morphine, hoping the molecular changes in morphine molecule would make it less addicting and useful for treating morphine addiction. But it didn't work. Now we had large numbers of opioid addiction from heroin use as well. Now I want to take a minute to ask, it seems like opioid addiction is everywhere in this country at this time. Why are people using drugs? It's important then as it is now. Why? Why do people use drugs? Anybody? Pretty, yeah. To get high, right? It creates euphoria for some people, and so they become addicted. Well, the continuing increase in opioid use, really narcotic use, that's what it was called at the time because there was cocaine and opioids seemingly everywhere, sparked a reform response, and the federal government stepped in. In 1914, the Harrison Narcotic Act took effect. It was administered by the Treasury Department, who kept tax records of narcotic sale and transfer. These records allowed officials to enforce existing laws, such as those requiring the sale of narcotics by prescription only. They could also prosecute unregistered opioid distributors, such as saloon keepers, imagine that, getting narcotics in a saloon, and street peddlers. The Harrison Act also prosecuted physicians who prescribed opioids for the treatment of opioid use disorder, and this is very important. What did all this regulation do? It had the impact of creating negative biases against maintaining opioid use disorder patients on medicine. It made sterile needles unavailable, and it promoted unreasonably long prison sentences for illicit use, illicit drug use, and misuse. By the 1960s, we found ourselves in another cycle. The scientific innovation this time was methadone. Without getting deep into the pharmacology of methadone, let me explain how it works. Methadone is a long-acting opioid agonist that provides stabilization effect for the patients with opioid use disorder. At a stable dose, patients no longer feel withdrawal at one end, and they don't get high at the other end. True to the cycle, public sentiment was that methadone treatment is simply replacing one drug for another. This plays into the puritanical idea that addiction is a moral failing, and what's required of opioid misuse patients is that they pull themselves up by their bootstraps. There existed a general feeling that methadone was same as heroin, and that the patients weren't truly sober. We now know the scientific and medical reality is that opioid addiction is a medical condition, and methadone is one medication to treat it. Similar to diabetes being a chronic medical condition, and insulin is one medication to treat it. The cycle continued with government regulation, establishing onerous rules for methadone treatment programs and those patients wishing to enter treatment. These regulations, to this day, make life-saving treatment with methadone a highly tedious and often inaccessible option for our patients. Now, the government was worried about methadone getting onto the streets, what we call diversion. And this affects policy. The backlash and suffering caused by these policies directly affected patients and providers. Heroin use surged in the 70s and 80s, mostly communities of color in urban areas. And don't forget that the Harrison Act really set the tone for negative bias toward maintenance of patients on medication for substance use disorders. The result was that healthcare providers' hands are tied. Providers can't prescribe outside of methadone clinics. Patients cannot get into treatment, and patients are reticent to get treatment even if it's available because of stigma and these tedious regulations.
So we're entering into the third cycle now. The scientific innovation at this time was OxyContin, a long-acting preparation of hydrocodone marketed to primary care providers for the management of non-malignant pain. Now, non-malignant pain is defined as pain lasting more than 3 months that isn't related to cancer. And research shows that non-malignant pain is not well suited for treatment with opioids. But nonetheless, OxyContin was marketed exactly for this purpose, and primary care providers were assured that it had minimal addiction potential. Well, within a few years, we started to see large swaths of mostly white, non-urban communities suffering high rates of opioid addiction and the beginnings of increasing opioid overdose deaths. The cycle tells us to expect government regulation, and it doesn't stray from the narrative here. Limits were set on the number of opioid prescriptions allowed. Doctors stopped prescribing for fear of federal investigations, and it became harder for patients to access OxyContin. The backlash was, and still is, the suffering of iatrogenic meaning caused by healthcare providers, iatrogenic opioid-dependent patients who no longer had access to the OxyContin they had been prescribed. Many patients turned to heroin and illicit synthetic opioids. It's dramatic to realize that many of these patients became addicted to OxyContin and are now dying today from a completely different drug, fentanyl. As the cycle goes, healthcare provider hands were tied. Overwhelming numbers of patients needed care. States needed more methadone clinics. There weren't enough to go around. And strict regulations kept them from opening quickly. Now, thankfully, buprenorphine became available as another treatment option around the year 2000. And even though it's less regulated than methadone, significant barriers existed for use. And then the criminalization of treatment and use come roaring back with well-intentioned databases to track physician prescriptions for opioids, including buprenorphine, as well as patient utilization of opioids. In California, this is the California Controlled Substance Utilization Review and Evaluation System. You may know it as CURES. It's promoted as a way to prevent diversion of prescribed opioids, and when used as a tool to discuss use and misuse with our patients, it is useful. But anecdotal information from prescribers tells stories of drug enforcement agency raids, palliative care in cancer patients having trouble accessing opioids for end-of-life pain, and tedious documentation issues are all continued barriers. And now we have the epidemic out there right now, illicit fentanyl. So what we see today in this 2020 graph from the Department of Health and Human Services is that in this current wave of opioid use disorder, the prescribing of synthetic opioids by physicians, OxyContin for example, is no longer a driver in overdose deaths. What started in 1996 with OxyContin use and the rise of opioid overdose deaths pivoted about 8 years ago when opioid prescribing was restricted and providers started to realize the harm from long-acting opioid use for non-malignant pain. Patients who had been maintained on OxyContin initially for pain were now left with few options other than heroin, other synthetic opioids, and now illicit fentanyl. Deaths from opioid overdose are now independent of medical prescribing. It's like a runaway train.
So in 2017, only 11 years after the aggressive marketing and prescribing of OxyContin, the U.S. Department of Health and Human Services, DHHS, officially declared opioid use a public health emergency. We commonly refer to this now as the opioid epidemic. So let's look at the numbers. According to the latest statistics from DHHS, nationally, 10 million people in the past year use illicit opioids. This can mean anything from illegal heroin and illegal illicit fentanyl use to taking someone else's opioid pain medication to using their own opioid medications not as prescribed. The definition is broad, and when we think about it, it helps us appreciate the vastness of the problem. the lack of a stereotypical addicted patient. For those of you who are clinicians, do you have an idea of a stereotypic addicted patient? And the need to be curious with our patients about how and when and why they take any opioid. In the past year, nationally, 48,000 people died from an opioid overdose. And this is part of the startling statistic that tells us overdose deaths have increased 519%. 519% since 1999, just 3 years after OxyContin came on the market. Now, let's narrow our focus from national numbers to the state of California. In 2021, there were 5,502 deaths from opioid overdose. 3,900 of those were from illicit fentanyl. As Alicia said, that's the current epidemic, fentanyl. It's here now. It is important to look at the morbidity that IV drug use causes as well. Some of the sickest patients I have seen inject drugs. And remember, the hypodermic needle that was invented in the middle of the 1800s? Who could have predicted that it would have such a negative impact on the HIV epidemic 130 years later? Needle use has left 318,000 Californians living with hepatitis C and another 129,000 infected with HIV or AIDS. While there are effective treatments for these two viruses, the same barriers we will discuss in a few minutes for opioid use disorder also exist for treatment of these diseases. Now, let's narrow our focus yet again and look at the numbers here in San Francisco. You may have all heard of Mayor London Breed's recent declaration of a state of emergency in the Tenderloin in response to drug overdose deaths. Statistics from the San Francisco Department of Public Health show that 82% of deaths among homeless patients during the COVID pandemic were related to drug overdose. Again, mostly fentanyl. That means we were better able to prevent COVID deaths than overdose deaths. The COVID-19 pandemic also caused disruptions in treatment access and care. Data show that 54 people died per month. 54 people died per month in 2021 from accidental overdose. In the past decade, the overdose death rate in San Francisco more than tripled from 13 to 49 per 100,000 citizens. So let's narrow this data one last time to the university and this room. We are not exempt. Sadly, here on campus, we've had students struggle with addiction and succumb to opioid overdose as well. The Bay Area has a rate of illicit drug use of 22 persons per every 100 residents, meaning 22 of 100 of us are vulnerable. The data also show that 10 out of every 100 in this room meet criteria for a substance use disorder. Our patients and our colleagues are suffering. And wherever you work, you will take care of patients with substance use disorders. We are all providers of addiction medicine services. These numbers provide straightforward data about the epidemic of suffering we are facing, but the barriers for treatment and healing are more complicated.
These complicated barriers offer us, all of us in this room, all of us joining from live stream, they offer us an opportunity to pause, to pay attention, and to educate ourselves as much as possible about the causes of this epidemic we find ourselves wading through. Sometimes, evidence-based data leaves disenfranchised communities behind. For example, while we celebrate the push in the past 2 decades to recognize opioid use disorder as a chronic illness, the literature shows that this change in narrative has largely left Black communities frustrated. If you remember the history that Evan and I shared, many activists and advocates point out that viewing opioid use disorder as a chronic illness that needs treatment instead of punishment only started to gain traction in the early 2000s when OxyContin began destroying white communities. The previous heroin epidemics in the 20th century affected mostly communities of color in urban areas, and our government responded with punitive measures based on now outdated stigmatizing attitudes that addiction was a moral failing. It's no surprise then that many communities of color are also reluctant to engage with the treatment community, which is viewed as racist by design. And let me explain what I mean by this. It means that communities of color are treated differently for the same illnesses their white counterparts have, including opioid use disorder. And it shows in poor health outcomes for these communities. It means that socioeconomic factors play a role in who has access to care. And it means that provider negative bias is often subtle, and while seemingly unintentional, it has grave consequences for these communities. Poverty and intergenerational trauma are also implicated as not only risk factors for developing an opioid use disorder, but also as a barrier to treatment for that same disorder. Dr. Nora Volkov, the director of the National Institute on Drug Abuse, calls on all of us to explicitly examine and address how structural racism affects health and how it leads to drug use and overdose deaths. She further reminds us that systemic racism is fueling the current opioid crisis, just as it contributes significantly to other areas of health disparities and inequity, especially for the Black community. She calls on us to ensure that evidence-based interventions tailored to these especially vulnerable communities are able to cut through the economic and social factors that drive disparities in substance use and addiction and reach all people in need of services. A policy brief out of Brandeis University discusses social determinants of health, which are increasingly implicated in the current opioid epidemic. And these include socioeconomic and environmental factors as well as health-related behaviors. Data show that social determinants of health are responsible for 80 to 90% of health outcomes and are especially important in behavioral health. We have learned that stigma and negative bias are barriers for patients, for providers, for communities attempting to affect policy changes, and for the most vulnerable populations, such as children born to mothers who used opioids during pregnancy. We have extensively talked about the history of access issues for patients seeking treatment for opioid use disorders, and it bears mentioning that this history lives on today. We don't have enough treatment providers, nor do we have enough treatment clinics and community organizations to prevent opioid use disorder, to treat opiate use disorder, and to support patients in remission from opioid use disorder. Now, with all of these challenges and barriers on the table for consideration, let's take a collective deep breath and talk about hope and what we all can do to help. We finally get to the core of our talk today, the what can we do part. Why do Evan and I have hope? As a doctoral student currently, I appreciate research and data. And like many of you, we pore over research articles, spend hours preparing to write papers by looking at the available evidence, and we agree that evidence-based practice is of utmost importance. But what I struggle with, and maybe many of you do as well, is how to translate that research, that data, those numbers, into actual patient care. How do we take our knowledge and transform it into some actionable item that we can employ when sitting in an exam room with a very sick patient suffering from opioid use disorder? When I was a new nurse practitioner almost 20 years ago, research was plentiful into the causes of addiction. Brain chemistry, structural changes at the receptor level, treatment options, genetics, a lot of information was out there. And I remember feeling a bit hopeless when I'd read the literature, as it didn't help me in my day-to-day interactions with my patients. It just made me feel like the problem was so much bigger than I had any ability to change. And then the National Institute on Drug Abuse started holding these conferences called blending conferences, where researchers and clinical practitioners like myself could get together and figure out how to apply the knowledge and the research. Understand how to make it relevant to us practitioners in the room with the patients. Help inform treatment program policies, and help develop education for patients and practitioners that had practical uses. And that gave me hope. And some of that blending of research with lived experience is what we'd like to share with you today, to help us leave here with hope for healing, not only for the patients suffering from opioid use disorder, but for healing within our healthcare provider community, because the opioid epidemic is difficult for us as caretakers as well.
First of all, let's talk about words. Words matter. Sounds like something I would say to my children, but they do. And using language to change our mindset is a first step in offering hope to our patients for healing. The words we use when referring to or about our patients are important. Many of us are well-intended and caring providers, but the words we use can be unintentionally alienating to this vulnerable population. Addiction is a treatable, chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. However, treatment modalities and the patients who need them are highly stigmatized. As health professionals, we too can perpetuate bias and stigma simply by our choice of words. It sadly isn't uncommon to overhear someone in a hospital or clinic say, "He gave a dirty urine," or "She's a junkie." Now, it reminds me, one time I saw someone present on words, and they had a slide that was just a picture of a drug screen urine bottle with dirt thrown on it. What was that? A dirty urine. I looked for that slide, I couldn't find it. But how would you feel if your doctor told you your urine was dirty? You would feel like there was something really wrong with you. Stigma is defined as discrimination against an identifiable group of people. Stigma towards our patients often arise from an outdated, pervasive view that substance use disorders result from a lack of willpower, rather than a chronic medical illness. People who feel stigmatized may feel angry or depressed, and these feelings may cause an unwillingness to seek treatment, lack of motivation to participate in treatment, and difficulty in establishing a therapeutic alliance with us, the healthcare provider, which I'm sure, as you know, is super important. There are a number of words that we can avoid that can help reduce stigma and negative bias. This is a good time to bring up the way we talk about infants born to mothers who use opioids. Babies aren't born addicted. They are born dependent on opioids and may or may not experience withdrawal syndrome, requiring treatment. Pregnant women are particularly vulnerable to stigmatization, and the negative effects of our biases not only impact the pregnant woman, but also her neonate. Now we can talk about treatment a little bit. As mentioned previously, methadone treatment was established in the early 1960s. And there you have a nice picture of the stereotypic methadone clinic. Buprenorphine was approved for use in 2000. How do these treatments work? These medications are both long-acting opioid agonists that treat short-acting opioids at the receptor level. Taken once daily, these medicines are designed to work to prevent withdrawal while not allowing the patient to feel euphoria from illicit drugs. Once stabilized, a patient doesn't need to spend every waking moment seeking and using drugs, but rather they can focus on recovery. Research established throughout the 80s and 90s showed that patients in methadone treatment programs had better outcomes than those in other types of opioid use disorder treatment modalities. Studies later on showed favorable results for buprenorphine as well. These studies were replicated over and over, and as such, they are accepted as the standards of care for opioid use disorders. Now, we have said methadone and buprenorphine treatment are effective, but how do we define effective? They are effective treatment modalities because they keep people out of jail and reduce criminality. They reduce or stop illicit drug use. They increase social productivity. They work to reduce the spread of HIV and hepatitis C disease. They reduce overdose deaths. Further, pregnant patients with opioid use disorder have better outcomes for themselves and their babies when in treatment with methadone or buprenorphine. And lastly, a government-funded study in California showed methadone to be a cost-effective treatment modality. The cost-benefit ratio of methadone treatment compared to no treatment for tax-paying citizens was 7-1, which eventually became a really strong argument to move policy. We don't define effective by getting patients off of treatment. If we understand the disease model of addiction, we know these medications are part of a maintenance program. You wouldn't taper an opioid use disorder patient off of methadone, just like you wouldn't taper a diabetic off of insulin. It's important here to stop and think about our own negative biases about methadone and buprenorphine maintenance, and explore whether these biases negatively shape our definitions of successful treatment for our patients. Many providers define weaning a patient off of these medicines and completing treatment as success, even though the scientific data show that stopping these medications leads to high rates of relapse. Like Alicia and her colleagues here today, nurse practitioner professional organizations are calling for you to understand your role in ending the current opioid epidemic. Dr. Moore, in this persuasive journal article, calls on nurse practitioners to prescribe buprenorphine and seek out opportunities to effect change in their patient populations suffering from opioid use disorders.
Let's talk about policy. Any of us that have taken a public health course might have heard of the concept of looking upstream to effect change. Search at the source. I spend time following the work of Dr. Sarah Wakeman from Harvard, who is a recognized national thought leader in substance use disorders and innovative ways to treat them. In a powerful interview last year, she stated that upon graduation from medical school in 2009, it was easier for her to prescribe fentanyl than it was to prescribe methadone or buprenorphine. Let's take that in for a moment. It was easier to prescribe a highly addicting medication than to prescribe the treatment for the resulting disease. Our U.S. policies have long skewed toward punishing people struggling with substance use rather than looking for treatment, a strategy that has not prevented the dramatic loss of life we are seeing now. But what can we do? Most of us here aren't accomplished researchers and thought leaders with a national platform from Harvard, at least not yet. But with hope comes my belief that the first thing we can do is utilize our education from USF. Practice the values that we have learned during our time here: advocacy, ethics. It was integrated into all of my doctoral schoolwork here. Being encouraged to follow what was happening on the local, state, and national level has allowed me to see the hard work being done by people such as Dr. Wakeman and my colleagues around the country. And remember, policy reflects our collective community bias. And so we call upon all of us in this room to advocate with science. Here are some policy proposals to pay attention to. The first is Medicaid expansion. Expand access to life-saving medications and eliminate that one barrier for our patients. Next, harm reduction policies. For those of you not familiar with harm reduction, these strategies aren't meant to treat, but rather mitigate or minimize harm. and literature shows that harm reduction strategies do not increase use. Some harm reduction policies to pay attention for are Narcan. Make it widely available in the communities with high opioid use and train people how to use it. There are some states that are advocating for Narcan to be available over the counter without a prescription. Let's do it. Support safe injection sites and needle exchanges co-located with substance use disorder services. Pass out fentanyl test strips so patients can tell if their drug has been contaminated, because most of these overdose deaths were not intentional. Promote policies that allow low threshold access to treatment. Third, reimburse for treatment. I mean, most private insurance won't currently pay for methadone. It will pay for buprenorphine. Buprenorphine can be more expensive, and sometimes the paperwork to get it approved is tedious. Another barrier. Fourth are policies regarding parity. Insurance companies still don't equally provide coverage for physical and mental health care, including substance use disorder. When COVID brought the world to a halt, methadone and buprenorphine were difficult to access, but fentanyl wasn't. The staggering loss of more than 100,000 people point to failed policies. These policies, Dr. Wakeman said, are often rooted in a misunderstanding of how to think about drug use and addiction. And remember, one final time, that policy matters. Dr. Carolyn Suffren, a colleague that I worked with locally here in San Francisco at Zuckerberg General Hospital, said, "Those who don't count don't get counted, and those who don't get counted don't count." This statement speaks volumes about the need for advocacy at the policy level to affect change for our patients in their day-to-day lives, to be seen and counted as humans. When we think about the history of opioid use in this country, we can see that before any of us in this room were alive, I'm pretty sure, laws were put into place that criminalized drug use. The wheels of stigma and oppression for individuals who suffer from opioid use disorder, they were put into motion long before we came into the picture. And yet today, research shows that healthcare provider bias is still a significant barrier for our patients. What does healthcare provider bias even mean? I mean, what does it look like? It looks like providers in the emergency room and doctor's office, and us here in this room. We have become more skeptical. We look for drug-seeking behavior more than we look for a person with a disease. It looks like my sickle cell patient who traveled out of town and had a sickle cell crisis. He's Black. He was in a strange ER. Couldn't get medicine for his pain. It looks like my colleagues calling me a drug dealer because I work in a methadone clinic. It looks like new graduates from nurse practitioner programs equipped with prescription authority for buprenorphine, like I have here from USF, because, we took the course, it was part of our curriculum, but then we graduate and we don't prescribe, for many reasons, of course, but the literature shows that fear that those patients are too hard to take care of. It's a major barrier. And it looks like a methadone-maintained patient of mine who was told in the NICU not to breastfeed her infant from lack of education by the resident. It's perfectly safe and acceptable to do so. So some of these examples may seem outrageous to us, but they represent the lived experiences of those of us who work in this field and our patients. So how can we make a change? How can we all leave here today with a renewed sense of dedication to take care of all patients, especially those with an opioid use disorder? Well, I wrote a paper on this during my doctoral work here at USF, and my paper is called From Bias to Empathy: Knowledge Transformation About Medication-Assisted Treatment Using Experiential Education Techniques. And in this paper, I argue that combating negative bias starts with education and increasing empathy. It requires a change in how we educate our interdisciplinary healthcare workforce, and a change in how we view our opioid use disorder patients. It requires help from a concept in dialectical behavioral therapy, a concept that states, until you radically accept the situation, you cannot accept change. But how does a cornerstone of dialectical behavioral therapy relate to us, sitting here right now, seeking hope? Well, it starts with the fact that we must all accept that we have patients in our exam room in our therapy offices who have opioid use disorder. We are all working in addiction medicine. We must accept that we have our own biases, and we must challenge them. We must accept that biases are an unfortunate but expected part of our culture and our upbringing. Not that we don't need to change them, but just that they are present. Accepting that we may have negative feelings toward a patient with opioid use disorder, or any substance for that matter, is step one. And this radical acceptance of the facts is necessary for step two, which is change. This radical acceptance does not mean we have to like it or even agree with it. It simply means we have to accept what is in front of us. Accept the patient who is coming to us for help. Accept the hardships they have experienced. Accept the decisions they have made. Accept that this patient needs help, not judgment, and then change can happen. It's one of the main dialectics we wrestle with as healthcare workers in this current illicit fentanyl opioid epidemic. But once we accept, how can we change? Well, I believe that education is one way. Taking care of patients with opioid use disorder is challenging, and we need the education while we're in school or after graduation to be effective at preparing us for real-life patient care with opioid use disorder. The literature shows that effective education for healthcare providers for both knowledge acquisition and reduction of bias needs to include an experiential component, such as clinical placement specifically with opioid use disorder patients, simulation even, or role-playing, or even what the literature calls consumer experience, meaning having patients come talk to students and tell their stories. I once heard a quote that went something like this: when we see ourselves as different than our patient, different than the person sleeping on the street, different than the numbers in the opioid overdose headlines, when we see ourselves as different than, we lose the chance at a shared humanity, a shared experience, an empathy response. We can't relate. And this is the cornerstone of our call for help, hope, and help. Explore our negative biases, challenge them, educate ourselves, and relate in a compassionate way to our patients.
Wow, you wrote a paper on that? Show off. What a brainiac. All right. Well, let's talk about the interdisciplinary approach. We know that it can sometimes be overwhelming when a patient with opioid use disorder shows up in your office. They are commonly not limited to one substance use disorder and can have co-occurring mental health illnesses. Add in a medical disease, and we have a very complicated patient. Opioid use disorder has multifactorial origins. Therefore, it takes a community of providers to address the patient needs from different perspectives. Public health, law and policy, psychology, and medical. It is important to know that whether you are the therapist or the nurse, you are operating within a continuum of care and should call on other professional expertise to help. It is likely that the patient already has interacted with other healthcare providers and has a team. If there isn't a team, you can build one. Further, every team needs a quarterback. There are a lot of sports references here. If there is no quarterback, be the quarterback. Some call this a case management approach. And as healthcare providers, we all eventually become case managers. When implemented to its fullest, case management will enhance the scope of addictions treatment and the recovery continuum. A treatment professional utilizing case management will provide the patient a single point of contact for multiple health and social service systems. Advocate for the patient across different disciplines. Be flexible, be community-based, and be patient-oriented. I want to tell a story. Some years ago in San Francisco County had two distinct oversight functions, one for substance abuse programs called Community Substance Abuse Services, and one for mental health programs called Community Mental Health Services. These silo bureaucracies were a detriment to patient care, and it made it difficult for all of us as providers. We knew that many of the substance abuse patients and mental health patients were one and the same. San Francisco County eventually and smartly combined these two oversight and funding entities under one roof and called it Community Behavioral Health Services. The mantra for our city's contracted agencies became any door the right door, as a sign that patients shouldn't be turned away from community-based organizations. This underscored a continuum of care and interdisciplinary teamwork approach to San Francisco's sickest residents. And this model is important today as we embark to work within our own disciplines to care for opioid use disorder patients.
Well, we've come to the end of our time with you. We realize that with our 45 minutes together, we have merely scratched the surface of this important topic. We appreciate that there is little nuance in this lecture format for the gray area in our and our patients' experiences. And we encourage you to use this information to start conversations within yourself and with your peers. But we'd like to leave you with a thought tonight. It's a metaphor that helps me when working with patients who are really suffering, patients who challenge my hopefulness, my resources, my energy. I remind myself that every patient's life is a book, and it's not yet complete. There are chapters in life stories still to be written, chapters from long ago that are forgotten and need to be reread. There are happy chapters, sad chapters. And then I think about my character in their life story. Who do I represent? How does my patient write about me? The hope comes for me when I realize that we can all change and learn and grow toward a more positive story together. If I've had a negative interaction with a patient in one chapter, it doesn't have to be the end of the story. There is hope for all of us as providers, just as there is for our patients. We can be the medical provider that finally helped this patient enter treatment for her opioid use disorder. Or we can be the provider that didn't help in chapter 4, but came back with new knowledge and new hope and made an impact later in the story. So we ask all of you, ourselves included, to think about what role you want to play in the life story of your patients with opioid use disorder. And together we can provide hope for healing and hope for a change in the narrative about opioid use disorder. Thank you.
Thank you.
Okay, thank you, Alicia and Evan. That was wonderful. We'll ask our panelists to come up. So we are incredibly fortunate today to have an interdisciplinary panel from the School of Nursing and Health Professions to continue this discussion of hope and healing along with Alicia and Evan. So please do join us. And as Alicia already said, we've just begun to scratch the surface. We have such limited time to take on such important issues. We have about 15 minutes here to hear from everybody. And what we want to start with is an introduction. So I'm going to hand the microphone off, and if you'll please introduce yourself and how you engage in the space of substance use disorders.
Hi, I'm Dr. Malamud, Dr. Yvette Malamud. I'm the Director of Clinical Training in the Clinical Psychology PsyD program, and I have a background in school psychology, substance use counseling, and neuropsychology.
Thank you. My name is Charlisa Bird. I'm a licensed marriage and family therapist. I have a private practice. I'm also an adjunct professor in a school of education. I also work at Santa Clara County in their custody behavior health. I'm also currently in school training with Peter Levine in somatic, to become a somatic experiencing practitioner. I am married with 6 amazing daughters, 2 awesome son-in-laws, and a 1.5 granddaughter. I was drawn to this field because my husband and I both grew up in San Francisco. So we came from backgrounds, from low socioeconomic statuses. And that gave us a lens to be able to view the world and see exactly how trauma, substance abuse, and addiction can affect individuals, families, and communities. So it drew me to become a manufacturer of hope and healing, an advocate for social justice, and a voice for those who are not heard. And I hope I can use this platform so you can just hear some and let me share some of my knowledge, both professionally and from the lenses that I view the world from in my healing process, and that there's hope for change and growth for everyone.
Hi everyone, Alice Finine-Green. I'm faculty in the Masters in Public Health program. I came to this work, I realized that we didn't go quite in order, but I came to this work around opioid use because it impacted my family directly in the early days of the 3rd wave of the opioid crisis. So it was one of the first probably fentanyl-related overdoses in 2004. And so my approach to working around substance use disorder is using storytelling methods. And so I really appreciated a lot of what both of you spoke about today in terms of using storytelling approaches to really increase empathy. And remember that when we're talking about people with substance use disorders, they are people beyond their substance use disorder. So they are friends, parents, sisters, brothers, loved ones, people with interests, and so I think it's really important to have that lens. And in terms of my particular focus, I know we talk a lot about interpersonal trauma as one of the key risk factors for people developing substance use disorders. But when I was doing my dissertation research, what I realized was that every single person that I spoke to, and I focused on mothers and pregnant people, had experience in the foster care system. And what I really ended up focusing on was thinking about the traumas that are experienced within the institutional setting as a direct form of violence that makes people afraid of interacting with the systems of care and that have negative impacts, especially around pregnancy and mothering. When we think about substance use as a chronic condition where it's expected that people relapse, we treat that really punitively, particularly for parents. And of course, there are extreme inequities across race that we see. So those are my focuses.
Hopefully I don't need to introduce myself again.
Good evening, everyone. My name is Trinette Radassa. I am an adult clinical nurse specialist, family nurse practitioner, and a psychiatric mental health nurse practitioner. I also teach here at the University of San Francisco. I am teaching in the DNP, FNP, and PsycNP program. Also, Alicia's committee chair and her advisor. Yay, we're going to get her through this. Did I pass? And my experience with opioid use disorder began when I worked as a family nurse practitioner in an urgent care back in New Mexico. I would encounter numerous patients coming into the urgent care with opioid use disorder, but they had other illnesses and they couldn't go anywhere else because of bias. And I was able to recognize that, and I welcomed my patients that came in for treatment for other various illnesses that they had. And a lot of them were turned down when they went to the ER. They had the list of drug addicts, the drug seekers that would come in. Currently, I work in alcohol use disorder treatment, which I really enjoy. And I have encountered a few of my patients with alcohol use disorder in addition to opiate use disorder.
Not so fast. All right, well, thank you for those introductions. So we have many questions that have come in from registration and from our live stream viewers. There is no way to get to them all, but and thankfully our organizer has given us a little bit more time. So we have until 7:30 to continue this discussion of hope and healing with our interdisciplinary colleagues. Yvette, if you don't mind, I would love to start with you. One of the questions that has come in is surrounding the treatment of co-occurring disorders. So that would be opioid use disorders with other mental health issues and medical conditions. So there is an identified need for interdisciplinary education. And the question is, how can we educate our interdisciplinary colleagues, clinicians, to provide culturally aware, linguistically appropriate, and then trauma-informed treatment to clients and communities in need? Okay, that's a lot. So start anywhere you wish, and we can continue on.
Well, it kind of starts with a division between mental health and substance use treatment that people were referencing, and there's a long history of separation of those two with different treatment approaches. So you have a lot of clients who have co-occurring disorders who are not really amenable to substance use treatment. Substance use treatment programs can't really handle people with serious mental health disorders or with co-occurring medical problems. And mental health treatment can't really handle clients who have both, who present with both. And this has been the case for a long time. People tend to specialize in their treatment approach. They either approach from a medical or a mental health perspective. And so we still have a lot of work to do. And I think that interdisciplinary education is a start to really sort of cross-pollinate and send trainees out and clinicians out into the world who have the skill set to deal with both. And similarly with culture and linguistic issues, we're just scratching the surface. We don't have enough competent supervisors who can supervise in the language that the clinicians, we're recruiting people who come from different cultural and linguistic backgrounds, but we don't have enough supervisors to supervise them in clinical placements, and so there's a gap there that needs to be addressed.
Wonderful, thank you. I want to continue that conversation around, there's been several questions that have come through around trauma, and trauma that is triggered for substance disorders, opioid use disorders, trauma-informed care. Is there anyone who particularly wants to take that on a little bit? What are the common trauma backgrounds that you might see? Charliza, is that something that you have any interest in taking on?
Sure, I can go. So yes, when we view substance and addiction from the lenses of trauma, you have to remember we are what we experience and what we're exposed to. So we bring everything who we are to our lived experiences. And if that comes from abuse, from car accidents, from growing up in a neglected home, however that looks, that can lead or manifest into us leading to substance addiction or abuse. And coming from, we have to remember that this country is actually built on a system of structural racism. So we should bring that out in the room right away. So by saying that, you have to remember there's intergenerational trauma that's been passed on for generations. So all that have to be acknowledged. So when we look at how we approach substance abuse and addiction, we have to bring in that past experience, that lived experiences that bodies of culture have had generationally. And how does that present itself? Not only does it present itself in sometimes in regards to fear, It presents ourselves in hopelessness, biases, being afraid to ask or seek the help that we may require because of fear of being judged, being belittled, downgraded. All of these things play a hand in how trauma plays out in the work that we do as professionals. And especially when you're dealing with trauma and substance use, they usually go hand in hand. I love when you guys brought that. I'm like, yes, bravo. You can't have one without the other. Well, you can, but usually you don't. And I tell my students all the time, if I'm suicidal, and then I'm admitted to a psychiatric ward to get help, and then I go home and I said, you know what, I'm suicidal again. They're going to let me come back in for help, right? But if I go and say, you know, I have an opioid addiction and I'm caught using, I get kicked out. So there's something wrong with the system. We may need to, and could you imagine that's another layer of trauma. So we're saying we're providing the supportive hands for trauma and for substance use, but instead we have these structural systems of bias that we need to break through so we can see each other, have empathy for one another, and provide a safe, empathetic place so we can say, I see you, and I accept you exactly the way you are. Your trauma, your abuse, your addictions, all of that. Enter here, these doors are open, and you know what? They're revolving.
Wow, thank you. Very powerful. Any other further thoughts on trauma and addiction? Anyone want to jump in? Oh, please, thank you.
Thank you. I really appreciated your points about intergenerational trauma and also calling out structural racism. And I think you brought that up in your presentation before, that when I started doing research around opioid use disorder, I was really critical of the fact that all of a sudden we were focusing on treatment and compassion. And historically, that has not been the case. That's a reason that jails in the United States are full of Black and brown people, in large part because of people serving time for non-violent drug offenses. And I think, of course, there's the interpersonal trauma. So for women, that tends to more be sexual abuse. For men, it tends to be more physical abuse. But again, thinking about how we treat people once they get into the systems of care. So a great example that I think of, and so I moved from Massachusetts, and so some of our treatment approaches are a little bit different, but one of the primary way that we get people into treatment facilities is by mandated treatment. So that's what is being proposed currently by Governor Newsom. And so if I'm someone that chooses to go into substance use treatment, I'm treated with compassion. I'm offered comfort medications so that I'm not suffering as I'm detoxing. But if I am mandated into treatment, I tend to be treated like someone that has committed a crime. And so for the people that I worked with, that meant often being put in handcuffs, being denied comfort medications. And so I think it's really important, and I'm really grateful that you brought up the piece around structural racism, because that's embedded into our laws, that's embedded into our treatment systems. And again, that you brought up that moral model of addiction, which was, we tend to think of as outdated, that, people that are, have substance use issues are weak, or they're, there's some moral failing, but we still see that really integrated into laws and the systems of care and into the institutions. And so I do think it can be hard for people that go into what I think of as the helping profession, so clinical care or social work. It can be really hard to also look at our own biases. And I think for me, because I had personal experience of my life being impacted by someone that was a substance user, I had to contend with a lot of those biases as I was going through my research. I think it's really important to remember that we all have them. We all watch movies, we all live in this world, and so we receive messages whether we like to think that we do or not. And so I think as long as we can be constantly thinking about that, our own positionality, I think that is really, really important.
Thank you. Thanks for spending on those thoughts. Alice, I don't want to let you off the hook, so hold on to that microphone for a minute. I do want to say, because I just can't help myself, because I also treat opioid use disorder, is that, and Alicia and Evan, please jump in, there is no reason to suffer in withdrawal. We have medications that stop the withdrawal. And one of the things I was thinking of when Evan was talking about why people use, there's euphoria, but I haven't experienced the bone-crushing symptoms of opioid withdrawal, but I've certainly watched it. And that is what my learning is. The people who continue to use are often trying to avoid that horrible experience of opioid withdrawal, which there is no reason. The adage I heard is withdrawal should be an event, not a process. You come in and we can take care of those symptoms immediately. There's no reason for people to suffer. So, Alice, let's go back to you and your current research in examining the intersection between structural and interpersonal trauma, mental health, and substance use among pregnant people and mothers. So could you talk to us a little bit more specifically on how to help people cope with, or how to cope with babies who might be in the intensive care nursery? I don't know if you do much of the NICU work. And what effects are we seeing on unborn children? And maybe Alicia might jump in. I know that's your area as well.
Yeah, so I'm not a clinical provider. I bring a public health perspective, so I'm not providing direct care to people. So I kind of think of my work more as like public anthropology, so understanding people's experiences. And I would say, the most important thing in terms of supporting mothers and families is to wrap them in care and services. So what we tend to do is separate families, separate children from their parents, separate siblings. One of the things that I didn't know until I started researching this topic was that if a family is impacted by a substance-using parent and they're put into foster care, the children, it's very rare for siblings to be fostered together because they're different ages, and each person who is like a licensed foster care parent is licensed to provide care for a certain age. So what I've seen a lot is that mothers of color have their children taken from them, and white mothers have home visitors, people that drive them to appointments, take them to parenting classes. So really for me, the number one piece would be providing supportive care and doing what we can do not to separate families, to provide them with the supports that they need to be present parents. I also think the other big piece for pregnant people and mothers is guilt and shame. And so I think acknowledging that for people, and this could be the reason that many people want to detox off of Subutex or methadone before giving birth because they're afraid of harming their child, where the science tells us that that's not the case. But I think, recognizing that guilt and shame also are triggers for substance use. And so thinking about ways that we can remind people that it's okay to be human and it's okay to sometimes do things that maybe you shouldn't do or you shouldn't have tried in the first place, but that's not the point. It's just human. It's human to sometimes want to escape. It's human to drink a glass of wine. It's human to drive too fast sometimes. It's human to experiment with substance use. And so I think really reminding people that they're not ultimately bad people, and making sure that in the treatment systems we are not exacerbating feelings of shame.
Thank you. Wow, moms are human.
Yeah.
Alicia, you want to join? I know that's some of your
Sure,
work
I
as
can
well.
add a little bit into the clinical piece. As a nurse practitioner working with the city's Family Addiction Center for Education and Treatment, the FACET program in San Francisco, I was prescribing methadone, and ultimately we were using Suboxone, Subutex, to treat patients during pregnancy, and I was also responsible for aligning them with obstetrical care usually at San Francisco Zuckerberg General Hospital. And I want to echo what Alice said about shame and guilt. There is a tremendous amount of that, especially in our pregnant patients. And what I see is that it often arises from this very non-uniform narrative that goes on with substance use disorder treatment. I would be telling the patient she's doing a great job by taking her Subutex every day. Her partner may be telling her she's hurting her baby and she should just quit. The different resident that she sees every time she goes in for an OB appointment is telling her a third narrative. And so that would be confusing for any of us, especially for someone who is already dealing with trauma and fear and probably doesn't feel very well either. She's newly in treatment with our program. So that's the one piece, is really unifying the narrative and using our words and our language to make sure we're all on the same page with our patients. The other piece I can speak to is the babies, the neonatal abstinence syndrome. We used to call it neonatal abstinence syndrome, and we still do, but now we understand that neonatal abstinence syndrome is really a broad term that means an abstinence syndrome in a newborn that can be due to any substance that the child could be dependent on in utero. It could be nicotine from tobacco, could be alcohol, could be Xanax or Klonopin or any of the benzodiazepines that are available on the street. And it's definitely can be from opioids. Now it can be from heroin, it can be from methadone, it can be from OxyContin, from Subutex. And so what we call it now is opioid withdrawal syndrome in the infants. And so what I want to say about that is it's very difficult in my clinical experience when I have a patient who is maintained in methadone maintenance or in Subutex and her baby needs to stay in the NICU. It's very hard to tease out exactly what is causing the withdrawal syndrome. Is it the tobacco, the nicotine she might be using? Is it the poverty that she's living in? Is it the lack of access to care that she had? It's very hard to say. And the data is a little squirrely on, what really happens in that regard. I will say that one of my patients that I remember most clearly, she did great in methadone maintenance and then delivered a healthy baby girl and went into residential treatment. And I got a call about, I don't know, a year into, maybe 6 months to 8 months into treatment or something, and the treatment program provider said, this patient, this baby, your methadone really ruined this baby. And I said, what's going on? And she said, well, the baby isn't crawling, the baby isn't learning how to sit up. And so I had my patient come in and I talked to her and I asked her, and what we discovered was that she had completely untreated and unrecognized OCD, and she never put her child on the ground. She was never encouraged to let her child sit on the ground. She was too afraid to. But nobody took the time to diagnose that or look for that, because in their mind, she was a methadone mom and there had been harm done to her baby. So when her OCD was treated and she was able to let her child touch the ground, of course the child's going to learn to crawl and sit up and advance that way. So that's a very poignant story that illustrates how bias and stigma affect our patients after delivery and always.
Yeah, thank you, Alicia. Trina, why don't you keep holding on to that, because since we're talking about clinical aspects, so you are the Director of Nurse Practitioner Programs at USF, and you are the chair of Alicia's doctoral project, and I think all of us can say job well done. So how do you inspire your learners? We talked about one of the barriers to getting care is getting more health professionals, interdisciplinary health professionals, to work in the area of SUD. How do you inspire your learners, your NP learners, to go into this specialty?
Well, I think that I inspire them by leading by example. I think that being actively involved and practicing in substance use disorder, it allows me to inspire my students by telling them my stories about the patients that I encounter and the success stories that I have with the patients. Also, as far as being program director, I'm looking at curriculum all the time and weaving throughout the curriculum information for the students, learning activities for the students regarding substance use disorder.
Great, thank you. Yeah, one of my favorite adages that I heard from someone else was one of the, unfortunately, best kept secrets in medicine is that recovery happens. And I do know you're a great role model, and you have students work with you in your own clinical site. So thank you for that. And any other thoughts on how we expand access to difficult to reach populations like rural populations or underserved inner city populations?
Did you want to speak to that, or I can? I can, yes. You know, there are a lot of challenges when we think about rural populations, and one of the big ones is access. We have a lot of people that live in rural areas that deal with addiction on a daily basis. There's higher rates of poverty in these rural areas. There is a low educational attainment. Sometimes they're unemployed. There is, like I mentioned, a lack of access to mental health care also in these rural areas. And so it's important that we educate others and make them aware and look at different strategies for accessing these patients. One of them that we have is our HRSA grant, which Alexa is the head person of our HRSA grant. And we're looking at teaching the students about telehealth, purchasing telehealth equipment, and adding that component into our curriculum also.
Thank you. And Alicia, you want to add to that?
Yes. I also wrote a paper on this.
She has been
It's
busy,
actually,
that Alicia.
It's actually my doctoral project was to develop and teach a course to community health workers in the Central Valley about substance use disorder during pregnancy and really educate them through the lens of how stigma and bias affects their communities. And so why we felt this was important was that, there's only a handful of us, but there's a lot of community. And really engaging the community with people who know the community, who live in the community, is such a potential valuable resource for all of us providers to start again changing the narrative of how we treat substance use disorder at the very bottom. And so I finished up on Thursday with my final teaching, and the community health workers will have spent 3 months with me learning. And they're actually coming to campus, which is really exciting.
Yeah, that's amazing.
Use your resources and look outside the box to access our patients where they are at. Don't wait for them to come in.
And I believe the name of that project is the Save the Children Project in the
Yeah,
Central
Save the Children is the organization in Fresno and Tulare counties.
Yeah, it's excellent work. Thank you for that. So we're getting close to the end of our time, but I was hoping, Shirley, so that you wouldn't mind pulling this all together in the end with a discussion on social justice as it relates to substance use disorder. And I will read these couple of questions came in, and then you can take it whichever direction you want to take it. So what are ways in which we can help minimize the negative effects that the opioid epidemic has caused in the fight for social justice? And how do we all continue this conversation for hope and healing from the lens of a cultural social justice worldview? Thank you.
I love it. Okay, so I have to round it up, hon. So first, we need to start by decolonizing substance abuse, and I would say trauma, because they go hand in hand. In other words, destigmatizing. So there's 4 ways that we can do that. So stigma requires 4 key things to survive: a lack of context, misinformation, discriminatory language, and bad policies, which we touch bases on many of these things. So our voices are more powerful than we think. We have to choose to get uncomfortable with being comfortable, which means having conversations that need to be had. Intergenerational trauma, past abuses, all of these things that we carry with us that define who we are. How does that look? We can't accomplish any healing, whether it's in substance abuse or trauma, without having a sacred space where you can breathe and feel safe. If you don't feel safe, nothing can be accomplished. No matter who you're talking to, you can have the best doctors, the best treatment team in the world. If they cannot see you and acknowledge who you are, there will be no healing possible. We need to provide compassion and empathy in everything we do, allowing ourselves not to have our clients enter our world It's time for us to enter theirs so we can give them motivation to want to heal, so we can get to motivation to want to change and grow and adapt. And then that way we start bridging worlds. That way we put everything together where we can say, we're all in this together. Your suffering is my suffering. I am enough because you are enough. We're only as strong as our weakest link. And as long as we start working together to make that change, that's where it happens. That's where the magic. We all have it in us. Like you said, acknowledging our own biases, being true to ourselves, knowing that we're uncomfortable. These conversations are uncomfortable. We don't want to discuss that, but it has to be, because everyone did not have the same equity. We're all not starting from the same line at the playground, and we have to acknowledge that. There's no pulling yourself up from your bootstraps. We all have to do this thing together. To thyself be true.
Couldn't be a better wrap-up. So with that, I'd like to invite Dean Pierce to come on up and close this up. Thank you, panelists. It has just been fabulous spending time with you and hearing all of your perspectives on this important issue.
That was so powerful. Thank you, Evan and Alicia, for leading this, and for all of our presenters for talking through the panel. Thank all of you, Father Paul, most especially, for being here tonight, and for our off-campus individuals who are participating as well. This has been a powerful Crawford lecture. I'm very, very pleased. I think that we can all go home and really contemplate things that we want to do on this topic and for this topic. So as we close, we've moved the reception to right through the back doors here in the Morosky room. So the wind has sort of driven us inside. So please join us for a reception. Please wear your mask while you're there if you're not eating or drinking. As a final note, could we please have a round of applause for our presenters and our audience? Thank you all so very much. We'll see you at the reception.